This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Neurology India, published in 2026. The paper is titled Level 3 Pretemporal Transcavernous Approach to Clip a Low-Lying Basilar Tip Aneurysm.
This is a great choice for today, Alara. Basilar artery aneurysms, or BAAs, are relatively rare in the grand scheme of vascular neurosurgery, but they are incredibly critical lesions. Because of their deep location and the high-stakes anatomy of the posterior circulation, they carry a potential for catastrophic outcomes if they rupture.
Exactly. And this specific case study focuses on a particularly challenging subset, the low-lying basilar tip aneurysm. When the basilar bifurcation sits low, meaning below the level of the dorsum sellae, the standard perional or even a traditional pretemporal approach might not provide enough of a surgical window to safely visualize the neck and the perforators.
That's where the Level 3 aspect of the Pretemporal Transcavernous Approach comes in. It's designed to extend that window inferiorly. Alara, walk us through the patient presentation in this report.
The study presents a 60-year-old woman. She arrived at the hospital with a modified Hunt and Hess grade 4 subarachnoid hemorrhage. As our residents know, Hunt and Hess 4 indicates a very serious clinical state, usually a patient who is lethargic or even in a semi-comatose state with potential hemiparesis.
And I imagine the imaging confirmed the suspicion of a posterior circulation event.
It did. Computed tomography angiography, or CTA, showed a low-lying basilar tip aneurysm. Given the rupture and the patient's clinical grade, the team had to move decisively. They opted for a surgical clipping using a Level 3 Pretemporal Transcavernous Approach.
Let's dive deeper into that approach. For the residents listening, why Level 3? In the hierarchy of pretemporal approaches, as we move from Level 1 to Level 3, we are increasing our exposure by drilling more of the bony constraints. A Level 3 approach typically involves a frontotemporal craniotomy, but it's the work at the skull base that defines it.
Right. In this case, the authors use the approach to navigate the complex anatomy of the cavernous sinus. By performing the transcavernous maneuvers, the surgeon gains a significant advantage in low-lying cases. It allows for a more inferior trajectory, which is essential when the aneurysm neck is tucked down behind the clevis. Without this extension, you'd be struggling to get a clip across the neck without putting excessive retraction on the temporal lobe or the third nerve.
It's all about the line of sight. If the aneurysm is low, you have to get lower. The paper highlights that this specific Level 3 technique is a valuable surgical technique for exactly this scenario. Was there anything specific about the surgery mentioned in the video abstract?
The paper emphasizes the frontotemporal craniotomy as the starting point, followed by the specific transcavernous steps to reach the basilar tip. The goal was clearly focused on achieving a safe clipping while managing the risks associated with a ruptured vessel in a Hunt and Hess grade patient.
And what about the recovery? For a grade 4 subarachnoid hemorrhage, the prognosis can often be guarded.
This is the most impressive part of the case report. The patient had what the authors describe as an uneventful recovery. Even more strikingly, at the 3-month follow-up, she was independent functionally.
That is a fantastic outcome for a low-lying ruptured BAA. It really underscores the point that while endovascular options are often the first line for the posterior circulation today, the surgical clipping via a Level 3 pretemporal transcavernous approach remains a vital tool in the neurosurgeon's armamentarium.
Absolutely. The authors conclude that this approach is specifically valuable because it addresses the anatomical difficulties of the low-lying position. It's not just about reaching the aneurysm, it's about having the visibility to protect the tiny, critical perforating arteries that arise from the basilar bifurcation.
Well put. For our listeners, the key takeaway here is the importance of anatomical familiarity. Understanding when a standard approach won't suffice, and being able to execute a Level 3 transcavernous modification can be the difference between a poor outcome and a functional recovery, even in high-grade hemorrhages.
It's a great reminder of the technical nuances required in vascular neurosurgery. The paper again is from Neurology India 2026.
Thank you, Dr. Alara, and thank you all for tuning in to the Neurosurgery Hub podcast. We'll see you in the next episode.
See you then.